descended upon us like nothing any of us have ever experienced before, certainly not in our professional lives. As a surgeon, a cancer surgeon in particular, we had to look at everything that was going on, and all of us became essentially critical care doctors almost overnight. The three issues that essentially drove us to stop any elective surgery, including much of our cancer surgery, was that there simply wasn't enough personal protective equipment. Every operation requires a lot of personal protective equipment. We were running out of beds in the hospital. And in fact, there was a terrible blood shortage. So both the hospital leadership, the department leadership, and New York State essentially closed all elective surgery. What then happened was remarkable. All of our operating rooms were turned into intensive care units because each operating room had a machine that's usually used to deliver anesthesia, and that was turned into a ventilator. Many of our surgeons turned into critical care doctors and looked after the incredibly ill patients that were being cared for in what came to be known as the OR ICUs. Nurses who had never been critical care nurses were called upon to take care of the 270 some odd ICU patients we had in this hospital at that time. It was a remarkable transition that people undertook. We had a pyramid of expertise so that there were critical care doctors and critical care nurses overseeing the care rendered to a huge number of patients by other physicians who hadn't done critical care in a very, very long time. The doctors, nurses, respiratory therapists all just did amazing things. We developed systems that the rest of the country are using. There was something called a SWAT team, where surgeons would go in to see a patient and they would do all of the procedures that that patient needed to then be put on a life preservation. That's intravenous lines, dialysis catheters, intubation, and they just went literally from room to room. That lasted for a month or so. Then the numbers of patients coming in through the emergency department started to decrease, and we very, very gradually started to assume more of our normal roles. At that point, however, we only had 2 functional operating rooms in the adult hospital. Those were very, very gradually converted because everybody was afraid of being inadequately equipped to take care of any new wave of patients that needed to be ventilated. We opened in early May. I did my first pancreatic cancer operation after 7 weeks of delay on a patient who couldn't be protected by chemotherapy over the course of that time for various reasons. Needless to say, he was desperate to have his operation. I was anxiously awaiting a safe situation in which to do his operation. And that happened, and he did well, and he went home a week later. Most of our backlog of cancer patients have had their operations at this point. We spent May and June operating in a limited number of operating rooms because they all had to be converted back, and that takes engineering activities. But we worked we had elective operating time on Saturdays and Sundays. As one of my surgical colleagues said when asked, would he be willing to operate on a Saturday or a Sunday? He said, it's just like every other day at this point in time, and that's the way we treated it. As of next Monday, August 3rd, all of our operating rooms will be open. We've been running for the last few weeks at about 90% available capacity. We've put in place a huge number of changes throughout the hospital and throughout our office areas and clinic areas to make seeing people safe. The waiting areas are like caverns. There are very, very few patients in the waiting areas. We're getting them into exam rooms quickly. We're not having extra family members. When I'm talking to a patient with one of their family members, we will often get the rest of the family on the phone or on a video chat so that everybody can participate in the care. Every patient who's coming in for an operation gets COVID tested. In the beginning, it was just before the operation, then it was 1 day before. Now we are at a point where we're testing everybody 2 to 5 days in advance so that we can have everything prepared. If patients are COVID positive, that doesn't mean they don't get an operation. If they need their operation, and they really need it now, we have a dedicated COVID positive operating room that gets what's called terminally cleaned between every patient, and any COVID positive patient goes to a segregated area of the hospital. Everybody's wearing masks. I'm not wearing a mask now. Everybody's wearing face shields. I have them right here. Whenever I leave my office, I put these on so that I'm both protecting my patients, my colleagues, and myself. I think we have created an incredibly safe environment. I will tell you one personal anecdote. My father was living in Florida. He's had all of his cardiac surgery. Here at Columbia, he's had multiple stents. He got into big trouble in Florida. Nobody there was willing to address his issue. We flew him up to New York. This was the beginning of May. He was seen by his cardiologist the same day that he arrived. He was hospitalized and he had his cardiac catheterization, and literally an impossible maneuver to get through a completely clogged artery by one of our star interventional cardiologists. I just say that to point out that people get sick from other problems in the midst of this. We can and need to take care of you. Don't ignore illness because it's safe to get your care now. And I'll stop there.
Thank you, Dr. Chabot. Now I'd like to introduce Dawn Hirschman, Director of the Breast Cancer Oncology Program at New York Presbyterian Columbia University. She will share with us her medical care of cancer patients, including chemotherapy, during the time of the COVID crisis. Dr. Hirschman?
So thank you, and thank you all for joining us today to hear about our experiences. I don't think there's a person out there that hasn't been personally affected by this pandemic. These are clearly unprecedented times. And I think, one of the great things about being at a top-notch hospital and a great cancer center is that we learn from our experiences rapidly and work as a team to really make sure that every decision we make is in the best interests of our patients and preserves patient safety. So there are 3 areas that I wanted to discuss because, it's hard enough to be a cancer patient undergoing treatment, to be diagnosed with cancer, or to have recently received cancer treatment under any circumstance. But to have this happen during this period of time of COVID, it's really a testament to perseverance. So we approached the issue of how to deal with COVID really from 3 perspectives. How are we going to maintain care for patients that need it, patients that were getting chemotherapy where their chemotherapy was essential? What were we going to do for patients that were newly diagnosed to make sure that every decision we made was in the best interests of the patient and would preserve patient safety? And what could we do for our long-term cancer patients that would ensure that they had contact, but preserve their safety. So to start, I want to talk about the patients that we had that were on treatment. These were patients that were coming in frequently because they needed chemotherapy to either cure their cancer or keep their cancer under control. We instantly put up systems in place so that we could have frequent virtual conversations with our patients to make sure that they were healthy and not developing symptoms. And that we could expedite their care when they came into the hospital. We reduced the number of people that were on the elevators. We reduced all unnecessary treatments so that patients didn't have to wait for their treatments. And as much as we could, we had patients get blood draws and other types of interventions locally close to their home. So when they came into the hospital, they spent as little time here as they could. My dedicated staff, our dedicated staff in oncology, were here every single day taking care of patients. Our chemotherapy center was open Monday through Friday, and we never turned anybody away. What we did do was we pre-screened patients to make sure that they weren't having symptoms, that nobody was coming in and potentially infecting everybody else. We made sure that we had proper personal protective equipment for ourselves and our patients and our nurses. And we spent a lot of time really being there for our patients, because in order to reduce the flow in and out of the hospital, we had to limit patients' visitation. So they couldn't come with spouses or other caregivers to their appointments. So we had to fill that role as a support system for our patients. The second thing we did in terms of patients coming in was to make sure that our patients that had symptoms were appropriately treated. And there was a lot of turmoil in the beginning about testing or not testing. So we started to instantly track all of our patients with symptoms, get them tested, figure out how to keep them out of the hospital. We figured the best thing we could do with this influx of patients coming into the hospital was to keep our cancer patients out of the hospital. So we set up systems with between telephone calls, daily telehealth visits with our patients and local labs, calling prescriptions into local pharmacies so that we could take care of our patients when they had a complication at home and keep them out of the hospital. We also tracked all of our patients that got COVID and became members of national registries. I can tell you on the breast cancer service, we've had 50 patients that were diagnosed with COVID during this period of time. And while you hear about all the bad outcomes, I was very happy to say that the vast majority of patients did very well and never had to be admitted to the hospital at all. The third population are patients that really had no place else to turn. Long-term cancer patients that were at home, didn't know what they should do, didn't know what risks they were at, and they were contacting us through our electronic medical record patient portals, through text messaging, through emails, through calls, and we were there for them to make sure that we were disseminating information appropriately so that patients would know what they needed to do to make sure that they were not putting themselves at risk. So a large part of our service for that patient population was education and reassurance. And then finally, I wanted to mention our patients that were newly diagnosed, because nothing stopped for those patients. Any patient that needed to have emergent surgery had emergent surgery. We tested them first, we made sure it was safe, but we got them the care they needed. We did have to alter our treatments to ensure patient safety. So often, instead of going to surgery first, we would put them on a medication so that they could avoid having to go to the operating room and monitor them closely. Or if they needed radiation, we would put them on hormonal therapy first so that they could delay their radiation until it was safe, monitoring them closely. We estimate from our analysis of about 300 patients, that about 50% of patients had some alteration in their care, but we did it thoughtfully and carefully to make sure that we didn't put any patients at risk from their cancer perspective. So with that all being said, I guess I'll conclude here to say that now that things are back and safe and we've put in all of these protocols, we worry about all the patients that aren't coming in for their routine care. So we want to do everything we can to reassure you and your families that we've put many, many processes in place and now feel that it's very safe for people to get the services they need, the cancer screening that they need, and the treatments that they need.
I'd like to say, thank you, Dr. Hirschman. I'd like to say we continue to screen our patients in our lobby as you enter the cancer center. And also anybody who continues to get treatment is also getting tested for the virus by nasal swab. So we continue to monitor our patient population to ensure that we continue to maintain a safe environment for everybody coming into the cancer center building. On that note, I'd like to now introduce Dr. Lisa Kachnik, Chair of the Department of Radiation Oncology. She will share with us the changes and the safety precautions she put in place for the radiation therapy program for our cancer patients. Dr. Kachnik, it is now your time to share your experiences.
Thank you. And thank you everyone for joining with us today. I'm actually new to the area. I came here from Nashville, Tennessee, right before COVID. But I feel my background and the tremendous team we have here at Columbia really just went into action quickly to make things safe for us and for you. So as soon as COVID came to New York City, just as you heard from Dr. Chabot and Hirschman, our radiation oncology department also jumped into action. And for those of you, radiation oncology is basically a fancy word for giving high doses of radiation to treat and cure cancer, often in combination with chemotherapy or surgery. So like the other physicians have stated, we too put very important safety protocols in place to ensure that all of our patients and our staff and our physicians remained healthy. I actually remember it well. I kept a journal. It was the weekend of March 15, when all of this COVID in New York City kind of came down. We started in radiation oncology by having all the staff wear masks and all of the staff and physicians do temperature and symptom screens before each of our shifts. We all knew not to come to work if we had any symptoms and to get tested. We then began to pre-screen all of our patients by telephone the evening before. It was actually the physicians, we all got together to do this, and then met every evening at 8 p.m. to discuss if any patients had symptoms that warranted testing. We then, when you came to us, because we remained open throughout at our sort of front entrance, as soon as you got off the elevators, you came off the elevators and went right to the gel dispenser. And then after you gelled, Dr. Chabot showed you some of our masks. We placed a mask on you, and if you had a visitor with you, we then did your symptom check and temperature check, and if all checked out, we took you to our waiting room where we kept everybody socially distanced. And we continued these processes all throughout. And then we made arrangements for any patient that was symptomatic to undergo immediate COVID testing right in our department. And just like for surgery, we had a special area that we did this in just for symptomatic patients. And these areas were terminally cleaned after the patient left it. We also, if it was easier for our patients, had you get tested closer to your home. And all of these protocols really worked. I think it was because we did it immediately in that sort of mid-March range. Out of our 80 or so physicians and staff and many, many patients as we remained open, I have the numbers too, less than 10 were diagnosed with COVID, which is pretty amazing. And these were early on and not from hospital exposure, but typically community exposure. I know for our physicians, the few that had COVID, it was their spouses that actually had it first. So I was really confident that our safety protocols were working. For in-person visits and for our radiation treatments, we're open Monday through Friday from 7 in the morning to 6 at night. But just like surgery, we often take care of patients in the evening and then on weekends if needed. And then, as I mentioned, to continue to keep everyone safe, especially our patients, we all continue to wear the masks and also the eye shields when we're working with patients that Dr. Chabot showed you on his screen. We have limited also, as I mentioned, the number of patients in our department at any given time so that we can all stay socially distanced in the common areas. And for our patients, if any of you are on, you'll see me walking around too, sort of scrubbing in between everything all day long. The radiation waiting areas, delivery machines, and exam rooms are continually cleaned. In fact, if you come for radiation, many of our patients have their own individual special device, and that's actually cleaned before and after and individually wrapped with your name on it and stored. We're also now performing COVID testing because we have the availability on our patients and our staff that have no symptoms. So all of our patients are having COVID testing before they start radiation and are required to have a negative test. But just as Dr. Chabot and Dr. Hirschman had stated, if our patients do have COVID and we feel that they require radiation, we just treat those patients at the end of the day in a special area that's also specially cleaned after the treatment. I think one of the most positive things for me and perhaps for all of healthcare that came out of this pandemic is the opportunity to quickly go to telemedicine. So we have video appointments, which is totally new for radiation oncology, for all of our new and current patients. So patients can contact us if they're interested in a video appointment for any continuum of their care. So if it's for diagnosis, for their treatment, or in follow-up during survivorship. And we can do this through many different ways. We could do it on your phone or smart device. We do it through our Epic medical record. If you don't have that, we do it on the Zoom platform, just like we're on now. And there's always the alternative of a telephone visit if we need to. And all of these virtual connections are really secure, so you don't have to worry about any private information issues. We can see our patients now where you feel more comfortable. So for example, for us, we also have a department in Bronxville at Lawrence Hospital. So if you wanna be seen there, we can come to you there. We can do a video visit, as I mentioned, and what we're really proud of, and we have started, are what we call your whole cancer care team doing a video visit all at the same time. So for instance, if you have pancreas cancer, you might have myself and Dr. Chabot on your same visit to give you your management options at that time. And then I'm really excited, and you'll hear more of this from the chair of radiology, Dr. Larry Schwartz, next. What you can also do is at any of our regional sites or at our main site, we can make arrangements now to get all of your imaging, so your CAT scan or your MRI and your laboratory test all at the same visit. And we can even give you those results during the visit where all of your physicians are on. So again, lots of positive things that came out of this pandemic that we're all very proud of, and that all of our patients can take part in. If you would like to make an in-person or virtual appointment, let us know. We can give you that information as well. But I think as our other physicians have stated, while these are really concerning times, we wanted you to know that all of us are here for you, and we're committed to continue to provide the highest quality care in the safest environment possible. Thank you.
Thank you, Dr. Kashnik. Finally, I'd like to introduce Dr. Larry Schwartz, Chair of the Department of Radiology, to discuss changes in operations and new safety measures that were put in place during the pandemic for imaging and other radiological procedures for patients. Dr. Schwartz, the podium is yours.
Oh, thank you very much, Gary, and everybody else on the panel. So in radiology, we've actually been open like the other departments throughout this time. However, in the abundance of caution, we did stop some screening examinations, such as screening mammography and lung cancer screening during the height of the pandemic in New York. We subsequently reopened those, and I encourage everybody who requires a screening exam to come back. All of our facilities are open. All of our facilities are very, very safe. As you've heard about, tremendous precautions are being taken to assure your safety. Specifically in radiology, we've expanded our services to 7 days a week, and we've expanded hours to early in the morning, if you'd like, or late into the evenings. All of our facilities are electronically connected such that you could decide to have a scan either at the Herbert Irving Cancer Center here at our main campus, or at Lawrence, or at Tarrytown, or at Midtown, at our Allen Pavilion, at our Choney Hospital for those children, at any facility that we have. And all your results, as well as your old imaging results and your complete medical record, will be available to all of our physicians in the Cancer Center. Additionally, as Dr. Kachnik pointed out, we're really trying to embed our services further with our referring clinicians. And we are now offering within radiology the ability for you to have your laboratory tests done at the same time as an imaging procedure. So you don't even have to go over to pathology, or certainly not to any outside lab. You could request this from any of your doctors here at Columbia, and we will be drawing your labs coincident with your getting a CT scan or an MRI or a PET scan. Another big advantage of this is that it means that there's basically one less needle stick for you to have. Similarly, what we're doing now as well is we're offering the opportunity to have a telehealth visit with any of our physicians immediately after the imaging exam. So you don't even have to go to another department, or another building, or another floor, or certainly not another facility. Instead, what we could do is immediately provide you with the results of your CT scan, PET scan, MRI scan, provide those to the referring clinician, to Dr. Schwartz, Dr. Kachnik, Dr. Chabot, Dr. Hirschman, or any of their staff, and they will communicate that information back to you really in real time while you're still in the Department of Radiology or in any other location that you'd like to be via telehealth. So all of those are available to you today. Simply have to just ask for it. We'll set that up for you, and that'll provide you even more assurance. One of the other things about radiology is that our machines are so heavy, like radiation oncology, that they're frequently located on the first floor. Our elevators are very, very safe, but if you don't want to have to take an elevator, just let us know and you won't have to. Many of our facilities are in places where we offer parking, and in fact, free parking, so that you could just park, walk into the facility. Our waiting rooms have been expanded. The number of patients that we see per hour has been decreased and spread out over the day. So our waiting rooms are not busy at all, and appropriate social distancing can be obtained. I'll stop there. I think we'll all be available to answer any questions specifically or in general.
Thank you, Dr. Schwartz, and thank you again, and all of our panelists. Now, at this point, we'd like to open up for questions. If you have a question you'd like to ask, please go and type it into the chat box and under questions and answers in the lower right hand, and the moderator will ask it live to our panelists.
I'll start because we have one question. So the question is, what about transportation for patients? And the attendee asks, due to many trips to the hospital for cancer treatment, transportation can be an issue for some patients that don't have a reliable method. has the Cancer Center thought about providing some transportation for their patients at risk? So I think Dr. Schwartz had already mentioned that we really try to limit your visits, whatever we can do to make everything on one day at a site in all of our regional sites that is most convenient for you. That is truly our goal. However, if you do have to come to main campus, we're happy for that as well. We will offer subsidized parking and can work with you to achieve that.
I'd like to add that the telehealth system has greatly impacted our ability to see patients without, in fact, coming on campus, unless, of course, they need systemic treatment. So many of our visits are done through telehealth, even discussing of CAT scans and results of blood tests. So we're trying to use telehealth as much as possible to decrease the need to travel to the main campus. But I'd like to add that we have really very little incidence of COVID now on our campus, which reflects also the decrease of COVID-19 in the community. And I think the keys to continuing to suppress the virus is to continue to maintain social distancing, 6 feet apart, use the critical face mask. You can use gloves on the hands, and if not gloves, then Pirelling as frequently as possible the hands. And I think this approach, which is being adopted not just in the Cancer Center, but throughout the whole city, will continue to keep the COVID-19 under control and avoid a resurge in the incidence of the disease. And we are clearly supporting all those efforts at our center. We continue to do checks for viral testing, temperature checks, and even have a safety monitoring system for our faculty and our employees. So now whenever an employee enters the building, there's also a check that needs to take place in order to ensure that there has been no COVID exposure or symptoms of COVID. So this is in place throughout the New York Presbyterian Columbia system, and I think it continues to be a sign of how we protect our patients on this campus.
So it looks like we have a two-part question, probably for you, Dr. Gary Schwartz and Dr. Hirschman. So the question is, I have an infusion session scheduled for tomorrow. Can someone accompany me? And then how much time before my appointment for infusion do I need to arrive?
So I can probably start that. We're currently following hospital policy about visitors. And we're trying, because of the space is limited, one of the goals of our program is to maintain social distancing. And if you visit our waiting rooms, you can see that many of the seats are blocked. And in fact, the waiting room, which used to sit on HIP 9, 30 plus patients, is now limited to 10. So in order to maintain social distancing throughout the whole institution, we do limit visitor access. If a patient has particular needs, such as wheelchair use and needs assistance, then we do allow a visitor to accompany a patient. But currently we're trying to minimize visitors accompanying patients into the center. We do know this puts a burden on the patient to come by themselves, to be let off in front of the HIP building, but that is the hospital policy, and we're following the hospital policy at this point in order to ensure safety to the whole population as a whole. And that's really the goal. The goal is to protect everybody the best way possible. And that doesn't mean there's some increased burden to the families and the patients, especially if they come by themselves. So until that policy changes on a hospital-wide level, we're still limiting visitors, though if there is an absolute need for a patient to be accompanied by a spouse, a family member, we will try to accommodate patient whenever possible to ensure the safety and the well-being of the patients coming to the cancer program.
But remember, we can always get friends and family on the phone during the actual patient encounter to get as close as we can to a true meeting with support family and friends. So there's no reason that we need to keep people in the dark. In the worst of it, when I made rounds on my patients in the hospital and there were no visitors allowed, If anybody had an iPhone, we would do a video chat, myself, the patient, and usually their spouse. They could see their loved one on the phone, and we could talk about any developments. So technology has really helped us bridge the gap with regard to visitors.
And I just wanted to mention, oh, go ahead, Dr.
I was
Hirschman.
going to say just one of the things that with every rule, there's an exception. If somebody can't walk in on their own, or they're in a wheelchair, they need some assistance, or somebody has cognitive issues, of course, in those circumstances, we allow somebody to accompany them, you know, if that's in the best interest of that particular patient. We want to be cognizant of people's needs while having the overall mission of preserving everybody's safety. The second question was really about infusions and injections, and we have, in order to speed things up and improve patient safety, we have established new areas. One is on the first floor of Milstein, the area we call Myrna Daniels, where there's a lot of space. We've carved out where patients can get their bloods drawn, they get their injections of certain types of treatments there, and then they come up and see their provider for their appointment. And so then only the patients that are getting IV chemotherapy are going to our chemotherapy center. And that's had the added benefit of increasing social distancing, decreasing wait times, which had, I think, been a big complaint before. We've made a huge amount of progress in terms of improving that experience for people. And I think most of the patients I've seen have said, wow, I'm really able to get in and out much faster, and they're very appreciative of the changes that we've put into place.
And I just wanted to mention, we also have a children's hospital and a large pediatric cancer program. So our children are special in that they do need a visitor with them to take them to their infusion and to their radiation appointments. And I think we have another question, Dr. Schwartz, for the other Dr. Schwartz.
This might be best for the Larry Schwartz to answer about CT scans and appointments.
So I'll read the question. I have an appointment for a CT scan on a Tuesday and a doctor's appointment on a Thursday. So Dr. Larry Schwartz, do I now keep my Thursday appointment, or do I get a real-time result at the hospital, or how do I arrange this? Can it be that I kind of do this all on one day and ask it to be arranged that way?
This is completely your choice and your decision. I don't know if your doctor has hours on Tuesday, but we could certainly obtain the CT scan before your doctor's appointment on Thursday. Or if you wish to keep your CT scan appointment on Tuesday and have a telehealth visit with your doctor on Thursday, if they approve of that, we could do that as well. So we want to give you as many options as possible. Feel free to reach out to my office or to your oncologist's office, and we could make those arrangements. Again, we're really trying to be as flexible as possible. So, either Tuesday or Thursday will likely work either for one or for both of the exams.
I'd like to add, it is possible to coordinate a visit with a CT scan the same day you see your doctor. So
Yes.
Same day scans are used, and it will result in a decreased number of visits to the center. It is possible. We've talked about having a consultation done in the radiology suite. It's an option for patients, but we have used quite frequently same-day scans on the same day of a follow-up visit to discuss those results on site. And I'd encourage you to discuss that option with your physician, your medical oncologist, radiation therapist, as an option to avoid duplicate visits during the same week. And the patients find it very satisfactory. Do we have additional questions, Christina?
I'd just like to make a comment on the same-day radiology because it brings up a point that I've been struggling with. And a lot of patients are choosing to get their scans locally in small hospitals and radiology facilities. And I'm seeing a lot of suboptimal radiology that we generally have to repeat. I'm seeing readings that are way off the mark, and we get our expert radiologists here to reread because the read seems so far off the mark. Radiology is critical to many patients' cancer care, and you need really good radiology, not just a CAT scan from anywhere.
That's a really important point, Dr. Chabot, and I would second that we have radiology centers now scattered throughout New York and Westchester County. If patients feel uncomfortable coming into the city, Tarrytown is an option. We have Midtown Manhattan if you don't want to come to the main campus. And I don't know if the other Dr. Schwartz wants to comment, but I have to really say that the experience of patients coming to these different sites within the NYP Columbia community has been very positive, and everybody's come back and said to me how safe they feel and how they really feel that it's the best way to get their scans done. And there is a quality issue, and we do have outstanding radiologists here who understand cancer and try to make sure the scans are really the best for the patient and help us as physicians make decisions about cancer care.
Now, thank you very much for bringing that up. In addition, my family has had scans now in the past month or two, my extended family, probably in every one of our facilities, including trying out the Tarrytown facility. In addition, we're open 7 days a week. So if you'd like to get your CT scan on a Sunday when it's less crowded, in general, Sunday morning, Sunday afternoon, we're available, to do that as well. Again, the response has been very positive, about the facilities and about the time that it takes you to get in and out. And of course, we then have the expert interpretation. And with all your other records being here, it is very important to keep that all together.
We have a new question, and maybe Dr. Hirschman guesses about mammography and about how it should be done, when it should be done, what patients should be more concerned than others about mammography, and how we're addressing that issue in radiology. So Dr. Hirschman, do you want to comment about mammography and screening and frequency along those lines during the post-COVID era?
Yeah, I mean, I think that, it's hard to answer an individual's question. I would sort of, really want you to speak to your provider about the optimal frequency for you, because it could be different from person to person. But what I can say is that we're doing both screening mammograms, diagnostic mammograms, procedures like biopsies if patients need it. Patients are getting ultrasounds, they're getting MRIs, and we even have clinical trials looking at various different ways of imaging the breast. And all of our clinical trials are now starting to get back up to speed. So I would say that it's very important that now that all of these services, all of the restrictions have been lifted, that people get the screening tests that they need. We know from the National Cancer Institute, from modeling experiments that were done, that delays in imaging, delays in colonoscopies, delays in other effective methods to prevent cancer can have a negative impact if patients delay too long. And so, an abundance of precaution has been put in terms of safety. Procedures have put into place to make sure that the waiting areas are really have limited number of patients, that, as Dr. Larry Schwartz mentioned, appointments are scattered throughout the day over a longer period, that there's really a lot of effort to make sure that everything's really cleaned up and down between patients. And, you know, mammography is right next to my office. I see every day, you know, how efficiently they're working, and I never see any crowds. So I would say really, if you're due for your next mammogram, you should schedule it. If you have any concerns about what type of test you should get, you should speak to your oncologist or other healthcare provider to make sure that they're ordering the right type of imaging test.
And I think the point Dr. Hirschman is also making, that we are able to go back to this new normal, and that we're fully open and operational here for all the testing that you need and have done. And the concerns for cancer at this point and having recurrent cancer, I would say, are greater than the concerns for coming down with COVID, based on the safety measures we put in place at Columbia. So we have to balance the risks and benefits of everything we do, and the risks of not having a cancer diagnosis done and not having appropriate screening, especially if you're at high risk for cancer. The risk there is greater than at this point than having a problem from COVID. So with that in mind, I encourage everybody who's watching this webinar to continue to have their appropriate tests done. The monitoring, the screening, it's essential for your health and the quality of your care. And we're ensuring that it's a safe environment to come to a Columbia and to see your doctors here on this campus, or by telehealth, whatever you feel comfortable with. Do we have additional questions? Let me see.
Yeah.
There's a question about CAT scans, Dr. Schwartz, about changing positioning. I'm not sure how that is, not quite a COVID question, but if you want to address it.
Yeah,
is it possible
no, absolutely. So
lying
you should,
flat for almost an hour as opposed to on their back? Right.
So in general, a CT scan shouldn't take an hour. PET scans do take longer, but please let the technologists and the radiologist ahead of time know that you have concerns about back and hip pain. There are several things that we could do. And Dr. Kachnik is also familiar with this from delivering radiation therapy. So number one, we could put more padding underneath the area that is bothersome. The next is that we can elevate the legs or elevate the knees in such a manner that your hips and back would hurt less, or provide further lumbar support. So please let us know about that ahead of time, and we should be able to alleviate that, potentially including doing it a little bit faster. Well, we're approaching the 12 noon hour. Unless there's some additional questions, I think we'll probably wrap up the panel discussion. On behalf of Herbert Irving Comprehensive Cancer Center and my colleagues today, I want to thank everybody for joining and this informative session on COVID-19 and cancer care. We hope you found it helpful. We hope we've been able to answer some of your questions. We want to remind everyone that we have many resources on our website, cancer.columbia.edu, and it's being updated all the time to reflect the changes in COVID and cancer knowledge and care. Additionally, we will be sharing this recording on our website, so you and your loved ones can access it at any given time. Please do not hesitate to reach out to all of us if you have any additional questions, either via our website or by phone, or if you have questions regarding your care. Remember, the key is use masks, wash your hands frequently, and maintain social distancing. And we'll continue to keep COVID at bay in New York City as we continue to maintain our active program of safety measures on this Columbia University NYP campus to ensure your safety for continuation of your cancer care. And on that note, thank you for spending time with us today, and all be safe and be well, and good luck for everybody, and take care. This concludes today's webinar, and I'm signing off on our end. Thank you very much.